Good morning to everyone in the room and those who are listening in virtually and part of our group. We are so excited to be here today. It seems like it's been coming for a while. So this is the Advisory Council on Alzheimer's Research, Care, and Services, and today's focus is on clinical care. We have an awesome panels that's going to be speaking today. The whole agenda is full of great information that I know that everyone will enjoy. So if you see the agenda, you can see that we have broken it up into a couple of panels. And for our conference for today, while it's all on clinical care, tomorrow we have another full panel for our long-term services and support that will be chaired by Helen Bundy Metzger. So we're very excited for that. So first we'll do introductions of our panel members. And I'm Dr. Adrienne Mims. I'm a geriatrician and a family medicine physician. I consider myself a quality improvement specialist in addition to that, having years of trying to work on primary care and trying to enhance the role that they're doing in caring for our older adults. So I will go to my right for introductions.
Hi there, everyone. I'm Helen Bundy Metzger, and I am one of two caregiver representatives on the Napa Council. And currently I sit as chair of the Long-Term Services and Support Subcommittee. So I hope you'll join me tomorrow for my agenda. Thank you.
Good morning, everyone. I'm Rhonda Williams. I represent public health. I'm the chronic disease prevention chief at the Vermont Department of Health, and I serve on the risk reduction and research subcommittees.
Good morning. I'm Erin Long. I represent the Administration on Aging at the Administration for Community Living, and I run the Alzheimer's Disease Program Initiative Program for states and communities and the respite programs at ACL.
Your mic is not on. Lisa, your mic is not on.
You guys are right here. Okay. All right. Oh, give me a challenge.
Hi, I'm Lisa McGuire. I represent the Centers for Disease Control and Prevention in Atlanta, and I'm in the Office of Science there. I serve on the risk reduction, the LTS, and the risk reduction subcommittees.
Hello, I'm Dean Cato. I'm the CEO of AG Roads, a group of nonprofit nursing homes out of Atlanta, Georgia. I serve on both clinical committees and, of course, our awesome committee that's going to present tomorrow. And I am a provider representative.
I'm Arlene Bierman. I represent the Agency for Healthcare Research and Quality. I'm the Chief Strategy Officer there in the Office of the Director. I'm a general internist, geriatrician, health services researcher, and my work is really focused on improving care delivery.
Good morning. My name is Sarah Fontaine. I am the CDMRPs within the Department of Defense peer-reviewed Alzheimer's program manager. So I manage a research program for Alzheimer's diagnostic, risk reduction, and care research. Thank you.
Good morning. I'm Bruce Fink. I'm a family physician geriatrician representing the Indian Health Service and work with the HHS Alzheimer's grant program team there.
And good morning, Sherry Lang, representing the Centers for Medicare and Medicaid Services, serving as the Deputy Chief Medical Officer for the agency. I am a geriatrician and gerontologist and a volunteer dementia care provider.
Good morning. My name is Brother John Richard. I am a person living with young onset dementia, specifically Lewy body dementia. And and I'm also a dementia advocate, and I'm glad to be on this panel.
Good morning. My name is Dr. Fawn Cothran. I'm the Hunt Research Director at the National Alliance for Caregiving in Washington, D.C. I am on the Long-Term Services Subcommittee, and it's a pleasure to join.
Thank you. Good morning, everyone. Roberta Cruz. I am here as a caregiver. I'm the other caregiver representative, and honored to be here, and I serve on the clinical care committee as well as the long-term supports. Thank you.
Hello, everybody. My name is Tisa Sherry. I'm the Deputy Assistant Secretary for the Office of Behavioral Health, Disability, and Aging Policy at HHS's Office of the Assistant Secretary for Planning and Evaluation, or ASPE for short. ASPE, and in particular, my colleague Helen Lamont here has the pleasure and the privilege of getting to convene this advisory council. So we thank you all for coming today and thank Dr. Mims so much for her leadership. My background prior to joining HHS is as a general internist and also a health economist and health policy researcher.
Thank you, Tisa. Good morning, everyone. I'm Helen Lamont. I am technically the designated federal officer for the Advisory Council. I am also a gerontologist, and I work in Tisa's office.
And we'll get to our people on the Zoom. Ken, can you unmute and introduce yourself?
Good morning. My name is Ken Kim, and I'm the Operations Director at a Community Health Center in Atlanta, Georgia, and I represent and serve those with limited English proficiency from refugee and immigrant communities.
Thank you. Joanne?
Good morning. I am Joanne Pike. I'm the CEO and President of the Alzheimer's Association, and I also act as the Chair of the Risk Reduction Subcommittee.
Thank you. Richard?
Good morning. Richard Hodis, Director of the National Institute on Aging.
Thank you. Joan?
Good morning, everyone. I'm Joan Weiss. I represent the Health Resources and Services Administration. I'm the Deputy Director in the Division of Medicine and Dentistry, and I'm an adult and gerontological nurse practitioner. Thank you. Pleasure to be here today.
Thank you, Joan. Susan?
Good morning. I'm Susan DeMorris. I'm the Director of the California Department of Aging, representing the state units on aging.
Thank you. Yakil?
Hi, good morning. My name is Jaquel Quiroz. I'm a clinical neuropsychologist and associate professor at the Massachusetts General Hospital and the Harvard Medical School, and I serve in the clinical care and research committees. Have a good day.
Thank you. Walter?
Hi, I'm Walter Korshets. I'm the Director of the National Institute of Neurologic Disorders and Stroke, and I practiced neurology for 22 years before coming to NIH.
Thank you. Eric?
Hello, Eric Weekly at the Substance Abuse and Mental Health Services Administration, and work with the Mental Health Block Grant and also with some other programs that work with homeless individuals and individuals with mental illness advocacy programs. Thanks.
Thank you very much. And we have we didn't do Randy? Randy? Oh my
Good morning. I'm Randy Bateman. I'm a neurologist at Washington University School of Medicine, and I also serve as the chair of the research subcommittee of NAPA.
And Randy, I'm so used to you sitting right next to me that I miss seeing you in the room. Thank you. And I'll turn it over now to Helen to run our federal updates.
Okay, here are my multitasking skills. So we are pleased to once again do our federal updates and go through all of the work that has been accomplished in the last quarter. Okay. Oh, that's how you can do it. Sorry. Thank you for your patience. There we go. Okay, so this is the order we're going to do presentations in today. It's alphabetical, I think alphabetical-ish. So we have quite a few updates from the federal agencies. Everyone has been very, very busy, particularly since the budget passed, which is great. And so I just asked my federal colleagues to move at a relatively good clip. So around a minute per slide. So we have enough time. And with that, I'll turn it over to Erin.
Great, thank you. So next slide. I'm just going to give you an update on some of the basic stuff that's been going on at ACL. We do have a funding opportunity open at the moment. This is just a slide with the information on our state community and tribal program, which has applications due on June 11th. And we had a call last week. If you are interested in finding out what we said on the call, the number to call in and listen to a recording is there. Next slide, please. Also wanted to let everybody know that last year ACL funded the Center for Dementia Respite Innovation. It's a grant that's with the Alzheimer's Association to identify organizations that have innovative respite opportunities, and the Alzheimer's Association is accepting applications for that grant. It was $5 million, and then 80% of that $5 million is going to go to grants to communities. Their application is due on June 1st, and there's a link there to the association's website to get more information on that opportunity. Next slide, please. So we do have a webinar coming up next month on May 22nd on the unique approaches to support brain health and risk reduction through education, exercise, diet, and art. We have a 10 webinar series each year that we highlight not only the work of our grantees, but that's going well, but addressing issues that are related to the NAPA Council. And there's a link to register to that webinar. It's a fabulous program in Puerto Rico that we're highlighting that's going to be great. And we're also going to highlight ACL's brain health education resources. Next slide, please. We did actually have a webinar last week on loneliness and social isolation that was very well attended. We had almost 1,000 people attend. We're going to have a recording of that webinar next week or soon on our National Alzheimer's and Dementia Resource Center website. There'll be the slide deck and the recording, and it highlighted some very unique ways to go at having memory cafes. Next slide, please. We also had one where we highlighted the use of care navigators for people living with dementia. We highlighted 2 programs. One, the state of California's CALS Connect program that's doing the care ecosystem and home meds evidence-based programs using community health workers in 3 counties in the state. So we highlighted their program as well as a rural program with an organization called OCCK in rural Kansas that is also doing the care ecosystem intervention. And those 2 will be posted on our NADRC website. Next slide, please. Wanted to announce that we have new leadership at ACL. Many people are familiar with Mr. Edwin Walker, who retired. It's hard to get it out even. Retired last month. He was with ACL, I think, for 36 years. And we are so pleased to have Carrie Benson come to us to fill Edwin's shoes. Carrie comes to us from the state of Minnesota. She's a longtime advocate for older adults and is just she's got an amazing history with all the populations that we serve. And Minnesota is a leader in so many things. So we're thrilled to have her leading the administration on aging. Next slide, please. We do have an update on our lifespan respite program. Just a couple of, I'm not going to go through it all because we're tight on time, but they did a webinar in February highlighting the Alter program. Many people are familiar with the Alter program, but they aid African American family caregivers and individuals living with dementia, and the Arch Respite Foundation hosted it, and you should be able to see the recording I believe Dr. Fayron Epps was the presenter on it. Don't totally know, but I'm pretty sure. We do have 2 funding opportunities at the Lifespan Respite Program that are available right now, and the links to those opportunities are there for the state enhancement grants and grants to new state for Lifespan Respite. And then there's just a bullet on some ongoing opportunities for resources. Next slide, please. So the CMS, I imagine, is going to talk about the new billing codes, the Community Health Integration and Principal Illness PIN codes. Our AC's Center for Integrated Programs created some resources to support people using those new codes, and this is just a link to that resource. Next slide, please. So ACL is actively trying to promote bridging aging and disability. Our Office of Intellectual and Developmental Disabilities has a program to support that they gave money to the National Association for Councils on Developmental Disabilities. They're funding 17 states, and they're allowed to do projects of national significance and do identify the needs of their communities. Just one example of what they're doing in terms of that is they did fund the National Task Group for Disabilities and Dementia to come to the state of Hawaii and do an NTG training. And then they're also working with the Alzheimer's Association to work on some legislative issues. Next slide, please. And that's it.
I just wanted to mention, you talked about care ecosystem, and we're going to have a full presentation on that later today. Thank you.
Arlene, over to you.
Good. Okay. Yeah, so I'm going to talk a little bit differently. I'm from the Agency for Healthcare Research and Quality, and we're actually tasked with improving quality, safety, outcomes, and equity of care, and take a person-centered approach rather than a disease-specific approach. So we don't have a lot of specific work on Alzheimer's and dementia, but are doing a lot of work on advancing person-centered care planning, and multimorbidity, which is really relevant to, this group. And I haven't given an update in a while, and I thought I would just give you an update on some of the work we're doing around care planning and also developing digital tools to be able to support this work. And just so you know, when we're talking about Alzheimer's disease, we're talking about multimorbidity because most people with Alzheimer's have multiple conditions, and the need to really develop care systems that provide that person-centered care and comprehensive care planning for people living with dementia. There's multiple barriers in the real world in terms of interoperability. People's data is spread all over the health system. EHRs are not interoperable. And also, I just want to highlight that, multimorbidity is actually a health equity issue because people from low-income backgrounds and underrepresented racial and ethnic groups develop multiple chronic conditions earlier and at higher rates. So it's really important to tackle it. I'm not going to go through the numbers because time, you can read those, but really people with multiple chronic conditions account for a disproportionate amount of healthcare spending, including 93% of Medicare spending. And many of you have seen this slide. Oh, the next slide. I'm advancing it. It's not doing it. So anyway, you've seen the slide before. This is from Sherry Ling in CMS. But what I really want to put out, if you look down the y-axis at Alzheimer's and dementia, this basically the colors show the number of other chronic conditions that people have. And if you look at Alzheimer's, well over half have at least 5 other chronic conditions, and the overwhelming majority have at least 1 or 2 other. So it is a norm. And, I practiced geriatrics and internal medicine for many, many decades. And often for me, the first sign that somebody was developing cognitive impairment or dementia was people who had well-controlled diabetes, heart failure, hypertension, who all of a sudden I couldn't control. And it was because they couldn't manage their medications anymore. So it's really important to figure out how to give that comprehensive person-centered care to people living with Alzheimer's and other dementias. In actually about a year ago, it was in April last year. I'm sorry, thank you. I'm so used to just dancing. ARC held a roundtable on optimizing health and function as we age. And we brought together 40 multidisciplinary experts who discussed how ARC can impact research, dissemination, and implementation of evidence to improve the organization and delivery of care with the goal of optimizing health, functional status, and well-being of the U.S. population as it ages. And this was both to inform ARC's dissemination and implementation work. A big part of our portfolio is getting evidence into practice. Clinical evidence, but also evidence on models of care, as well as our future research agenda, because we're a research funding agency and we fund health services research. Next slide, I remembered. And one of the things, we have so much evidence for models that improve care, for how to treat dementia, how to diagnose it. It's not getting to people. And, one of the things that came out of the meeting was the reason why it's so hard. And this is some work that ARC is working now to tackle. We need to align policy, payment, but we also need to change the culture of healthcare delivery because so that people want to do this. And also we need the evidence generation. We need to know what works. Actually, Adrienne was at that meeting and we welcomed her contributions. So I'm just going to give a definition to get everybody on the same page. What are we talking about person-centered care? And person-centered care means that individuals' values, preferences are elicited and once expressed guide all aspects of their healthcare, supporting their realistic health and life goals. Person-centered care is achieved through dynamic relationships among individuals, others who are important to them, and all relevant providers. And the collaboration informs decision-making to the extent that the individual desires. And this is the definition from the American Geriatric Society. So just quickly, and I'm going to go through these slides very quickly, but you have them for reference. 2 projects that ARC is doing to advance this work is actually in partnership, funded by ASPE through the PCOR Trust Fund. We're developing an interoperable shared electronic care plan for people with multiple chronic conditions. We're partnered with NIDDK, and basically we're building the capacity for pragmatic patient-centered outcomes research by developing an interoperable electronic care plan to facilitate aggregation and sharing of critical patient-centered data across home, community, clinic, and research-based settings for people with multiple chronic conditions. Oh, next slide. This is just a graphic to show data now is all over the place, and you want to have it in one spot. Next slide. So actually, ONC developed this definition of a comprehensive shared care plan back in 2016, and I really like it. It gives person direct access to their health data. It puts the person's goals at the center of decision-making. It's holistic, including clinical and non-clinical data, and it follows the person through both high-need episodes, acute illness, and periods of health improvement and maintenance, and allows team coordination. The care team is able to view information relevant to their role, identify which clinician is doing what, and update other members of the interdisciplinary team. Next slide. So, for time, I'm not going to go through this, but basically our apps, we have 2 apps. We have a clinician-facing app, and then we have a patient and caregiver facing app. And we developed them using user-centered design with input from frontline clinicians, patients, caregivers to make them useful. We're pretty far along. We're in our last round of testing. We're doing it through a contract with OHSU, and we will be done by the end of the year. Next slide. So just to show what's, the data elements that are in our care plan, we have information on the person and their plan, demographics, who's on the team, who's the caregivers, paid and unpaid. We collect all health concerns, all the basic clinical data, but also include social issues like health-related social needs and risks. we collect goals, and we collect clinician goals and patient and caregiver goals to start conversations. And I'll show a little screenshot of what that looks like: interventions, treatments, meds, etc., and outcomes. And also, it's really designed to be a tool for care coordination. Next slide. So this is a screenshot. I'm sure you can't read it, but you could see patients and clinicians could, enter their goals. So if a clinician's target is a certain hemoglobin A1C, but the patient wants to go to dance at their daughter's wedding, you could start talking about how maybe working towards that can help you get their goal and help people develop a plan. Next slide. So basically, the e-care plan is designed, it has benefits for clinical care, quality improvement, and research. And just quickly, improve communication and care coordination across all these different people and settings of care, access to patient caregiver reported and patient caregiver centered data, improve patient safety, and also reduce redundancy and duplication of orders, which can reduce cost. And, I know when I was, I practiced for decades and decades, and how much time it took me to aggregate all this information on my patients when they saw, specialists or had a, short stint in the hospital. This can really reduce burden on providers, clinicians, caregivers, and patients alike. Next slide. But also, it's really important for research, and I think this is what's relevant to this committee. Is you can't do data if you think about, we have such gaps in our data for people with multimorbidity because we study one disease at a time, and people with multimorbidity are often excluded from clinical trials. So this is actually aggregating real-world data to enable real-world research, so you can get a holistic research on people who we don't really have a whole lot of evidence on. So we get complete data, comprehensive data, and real-world data. Next slide. And also lots of benefits for quality improvement. And maybe after I finish, maybe Shari and Jim Rudolph will talk about CMS. One of the reasons I decided to bring this up today is because CMS is exploring how to build on the architecture that we developed to be able to add dementia care and use it to improve delivery of dementia care. Next slide. So we've been sponsored by HL7. For those of you who don't know, that's the HL7 International is a data standards body for EHRs. So we have actually an implementation guide and data standards and architecture for care plans that other people can build on. And we're really excited. We shared our architecture data elements with the interoperability standards work group of high tech. And they recommended to high tech to elevate care planning in the next version of USCDI version 5, which are the requirements for EHR. And we just learned a few weeks ago that high tech unanimously voted to move that forward to ONC for consideration. So we don't know whether it will be included, but I think that will be a big advancement if it does go forward, because it's really, improving EHR's capacity to do this work. Next slide. So I know I have to be quick, but we'll just spend 2 minutes, 1 minute maybe on the next two slides. So the other thing, so we're doing is developing the digital tools for research and quality improvement care that we can do this. But we're also starting a big collaborative to really try to scale and spread person-centered care planning nationally. I'm not going to read this now because of time, but the next slide. And we're really excited we had the first meeting of our technical expert panel a few weeks ago. We have a partners roundtable, which includes leadership from health systems, state health agencies, payers, professional societies, and federal partners. So the idea is we need health system leadership to be able to support the frontline people to be able to do this work. And then we're convening a learning community of people. There's a lot of innovative work going around the country, but people, could share with each other what they're learning. So we're creating a learning community, and we're going to bring all these groups together in a summit in the spring of 2025 to see if we could come up with some strategies to help make person-centered care planning more a part of routine practice. So thank you.
Thank you, Arlene. Okay, it's us. Okay, so this week or last week, HHS celebrated Care Week, which was the 1-year anniversary of President Biden's Care EO last year that touched on a number of different actions the administration is taking and then was charged with taking in order to improve the workforce of people providing care to older adults and people with disabilities, as well as child care, and also to support family caregivers, recognizing all of those groups work together to optimize how families and people function. And one little provision in it, ASBE and the Department of Labor were charged with leading, focused on improving data on the workforce, delivering home and community-based services. You might be shocked to know, unless you work in the field, that we know very little about that workforce. We know roughly how many people there are and roughly how much some of them get paid. But beyond that, we don't have good data on why they come into the field, what their work is like, things like injuries, wages, other benefits. And everyone around this table knows how important that workforce is to supporting people with dementia to live in their homes and communities. And so we got together with the Department of Labor, in addition to our partners across HHS, and looked at what are the key policy questions we have about this workforce, what data do we currently have, and where are there gaps, and use that to make recommendations on high priority actions to fill those gaps. And that culminated in an issue brief that came out last Thursday on the ACL website focused on the direct care workforce. And we will have a webinar on May 21st talking both about the recommendations and then also what some innovators are doing in the field to already move things along for this data source. Okay, Lisa, over to you.
Okay, does this one work? Okay, good. All right, next slide, please. The first thing I'm going to share with you today, I'm going to share first a variety of things that our awardees, our HBI and BOLD awardees have been doing in the past few months. And so the first thing I'm going to share with you is a partnership that the Alzheimer's Association established with NACHO, which is the National Association of City, Health, and County Officials. So what you're looking at here is a new resource, Integrating Brain Health into Health Improvement Planning, was developed by that amazing partnership. What this tool does and how you can use it is it brings together the Healthy Brain Initiative and the MAP frameworks to provide health departments with information they need to integrate brain health into health improvement planning action. So if you don't know what the MAP framework is, that's mobilizing for action through planning and partnerships, which is a really widely recognized community-driven strategic planning process that's for the purpose of achieving health equity. So please check this out on the website. Next slide. The other great thing that's been going on, I've been sharing with you some of the updates on this, is in 2019, CDC and the Alzheimer's Association launched the first ever roadmap for Indian country. You can see this is not a typo on this slide. We are working on the updating process, and one of the big things we are updating is the name, based on feedback from listening sessions, our in-person leadership meeting. So the roadmap for American Indian and Alaskan Native people, and it's still controversial if it's people or peoples. Everybody has an opinion on that one. We'll see what our style guides say. But that will be released in, it'll be released in November of this year. So at this point, we're working on the actions. We're working on the graphics, making sure the graphics are definitely very representative. A lot of the feedback that we heard on the version that you're looking at here is not all people who are American Indian Alaska Natives saw themselves in the document. We had a really hard time getting pictures that represented, that didn't all show deserts and mountains, but really people could recognize and see themselves and their families and communities in that. Next slide, please. So in preparation and some of the back work to really help support the development of the new roadmap, our awardee, the International Association of Indigenous Aging, or IA Squared, they hosted a variety, and this is an organization that focuses really on American Indian Alaska Native peoples. I'm going to say peoples because that's my vote. They hosted a variety of listening sessions in January to try to get as much support and information as you can see They had about 160 people in those listening sessions, and there was a lot of conversation on brain health, caregiving, what are the right terms, and everybody has an opinion, and it's going to be really interesting to see how all these discussions weigh out. Next slide, please. This is from our Bold Center of Excellence on Risk Reduction. So this is a series of infographics that are looking at modifiable risk factors for dementia and the ability to address those risk factors that are affected by social determinants of health. So please check out this series. There are 5 different infographics, and they're listed or shown at the URL at the bottom of the slide, please. Next slide. Our Bold Center for Dementia Caregiving has been having a series of amazing webinars. So these that I'm showing you are webinars that recently happened. They are recorded and archived, and the URLs are for those listed. And you may recognize occasionally some of the speakers as people we hear here as well. So this one was on Utah. Next slide. And this one focused a lot on using some of the public health approaches of caregiving and related to data. And data is always, as Helen pointed out, a very challenging issue in this space. Next slide. And they have a series of webinars that are forthcoming, and those you can get information from their website. Next slide. So one of the Healthy Brain Initiative awardees is University of Illinois, Chicago, and they focus primarily on people with intellectual and developmental disabilities through their Health Matters program. So this slide just highlights some of their accomplishments and their work with IA Square, as well as their work with Us Against Alzheimer's and the Nurse Fellows program that I'll share a little bit about later. Next slide. This has a lot of stuff on here, but if you don't look at anything else, look at number 1. Number 1 took the Gerontological Society of America's KAER model or toolkit, which is Kickstart, Assess, Evaluate, and Refer. And they have one of those for dementia. If you haven't seen it, please check it out. But this one is looking specifically for dementia care for adults with intellectual and developmental disabilities. The framework, I like the framework, but the framework is really good and thinks through the process and making sure that we have especially that referral. And the really good thing that this one does is really looks at some of the challenges of evaluating dementia in people who do have intellectual and developmental disabilities and how you do that and tools and resources for that. Next slide. This is a series of slides, but the key is get this URL. This is an amazing toolkit that our Bold Center of Excellence on early dementia or early detection of dementia developed. It's a really nice step-by-step guide. It is available on their website. Next slide. And I'm just going to walk through a few things. One of the things that it talks about, and I know to this room, I don't have to say why early detection matters, but outside of this room, we still have some convincing to do and why it's important to have some timely diagnosis. And so this is some of the language or the verbiage to help people see that or to be able to explain it to other people such as their patients, family members, or even maybe their professional colleagues. Next slide. This shows some of the other information that's in there of like why it's important to prepare for cognitive screening and things that you can talk about with your patients as well as thinking about. Also next steps of what happens afterwards. That's okay, next slide. Helen reads fast. Also has some tools in there looking, their toolkit has an overview of 7 individual performance-based and informant-based screening instruments recommended by American Geriatric Society, Gerontological Society of America, U.S. Preventive Task Force, and has practical details on the implementation, how you can get access to them, how long it takes to administer them, language adaptations that are available, and also what you need to know training-wise to utilize them. Next slide. This just gives a little bit more about their approach involving healthcare, public health, and the community, and seeing that 3-sector approach all working together. And then the right hand of the slide is a little teaser of the toolkits that are coming next. Next slide. There was a webinar describing it, so the slides will be posted, so you can click and you can watch the video clip that's about 2 minutes long. So next slide. So along this very similar topic area, next slide, Helen, is some work that the University of Washington is doing on that KAER model. So what University of Washington has been doing with some CDC funding is looking at the feasibility of that model and implementing it within a healthcare system. They have been doing a lot of work, testing it, training providers, getting provider feedback. And so the things that you're seeing here is a result of several years worth of their work and effort. The first thing and the most exciting thing is they have developed a free CME course for primary care providers, which is available on CDC Train. You see the URL there, you see the course number. My words on the right-hand side shifted. That is my fault, not theirs, so that's not a reflection of their course. But this course will help you learn how to evaluate cognition. She went fast on me again. Set a plan and tips for managing MCI and dementia. Next slide, please. So here's a little bit more about some of the information. It's prepared for implementation, toolkit for change in the clinic. So they have a toolkit that is developed in their set of materials that talks about how you can modify things within your patient flow and clinic, and some checklists, a lot of different checklists for things for you to look at as a provider and think through and evaluate with your patients. Next slide. There's also included in their toolkit an EHR checklist looking at some very important factors that can be linked to brain health. Next slide. The really neat things about their cognition and primary care is the 3 phases. So first, you saw the training. You saw the CDC Train course. Second couple slides, you saw the EHR tools that they have available that you can utilize. And third, everybody likes to get mail because we don't get that much mail delivered anymore. You can have a clinic box kit shipped to you for no cost. Next slide. This just shows a little bit here too. So that's the last thing with that starter box kit, mailed to clinics to make it easy, put folders in place, and to put into training and practice. So this is all available at their website for cognition and primary care, which I see is not on this slide, but let me know and I can help you get connected. Next slide. This is some of the work that Us Against Alzheimer's is doing with their Nurse Fellows program. They just awarded their third cohort of Brain Health Equity Nurse Fellows. The 2024 cohort has 4 fellows from 7 states and DC. And the really neat thing about the way they're working this fellowship program is alumni fellows from previous cohorts are helping to train and also educate the current list of cohorts. Next slide. A little bit more about the work with the Brain Health Fellows from Us Against Alzheimer's Brain Health Equity. Next slide. And thank you.
Thank you, Lisa. Next, we're turning it to CMS, which is going to do a hybrid presentation. Ooh.
No, thank you so much. So, and just to say what we have been doing with our images up front is to find real beneficiaries and representing the people who it is that we are serving. And today, the hybrid part of it is I'll provide a few remarks, but also wanted to introduce you to some of our team members who are really going to be critical in the implementation of the work. So I'll say a few remarks and then turn it over to Dr. Lenise Cummings-Vaughn, who is a geriatrician practicing, but with CMS as a medical officer full-time and in the quality measurement and health assessment group or value-based incentives group, change the name. And Pauline Carey Martin will cover the long-term care staffing role as part of the writing team. So I think it's important for us to be able to introduce you to the people who are actually doing the work. So with that said, if I could have the next slide, please. So I know many of you, all of you have been really interested in the progress that the CMS registry has been making. And as a reminder, it is one of 4 approved studies. What I want you to take away is that this national coverage determination, which is under coverage with evidence development, is still open for additional studies to come in and be considered. They simply need to propose the study that is designed with the intent of answering the questions that are important for both policy making, but for clinical purposes. So if we could have the next slide, please. And just to also say that we anticipate that we'll be able to share more by the next quarterly update, or July, which will be the 1-year anniversary of the CMS registry, so that more you can all understand where we are in progress. One question for you all to ponder, and we can have this, we can discuss this further, is as far as an update and as far as numbers, we've been asked for numbers. The question is, what numbers are you interested in, and where and how would we display these numbers in ways that are that meet your curiosity, but importantly that are useful and also timely. And I mentioned the timely piece because claims take a while to process and to mature, and so it depends on where in this journey of data maturation, reporting through maturation, as far as which numbers you're interested in. Back away from the space bar.
It's her magnetic personality.
So more to come on this point. Next slide, please. I also wanted to mention and to remind this audience that there's a lot of work that CMS has been in action on that is under the rubric of the CMS behavioral health strategy. So it doesn't, have a specific flag for Alzheimer's disease or Lewy body disease or other forms of dementia, but the whole intent is to improve access and quality of care to people who are either at risk of cognitive impairment, dementia, or have a diagnosis and are living with dementia, and their caregivers. So we have a CMS behavioral health strategy slide that includes a updated list of actions that have been taken across Medicare, Medicaid, and Marketplace, and it's all on this accessible here. Erin's call out for the principal illness navigation. It's amazing how fast time flies, because we reported out last quarter, but also finalized last year. So, we can certainly, if you look at the fact sheet and if it is of interest, we would be happy to compile some of more long-lived actions so they don't vanish, since in order for any of these actions to no longer take effect, like rulemaking, we would have to intentionally take it out. So it could actually serve as a reference and a resource. So I've printed some copies of the CMS behavioral health strategy, and I'll leave it at the end of the table here for your perusal, and to think about how do we convey some of these actions and remember that this also applies to people who this committee cares about. And just to also mention, CMS hosted a hybrid 2024 quality conference in Baltimore, and we hosted a specific session that included Dr. Adrian Mims, Dr. Esther O, and Tonya Seifer from our guide, leading our guide efforts, really to keep the interest up and understand what it is that people want to know that we haven't said, or to figure out the intricacies, the nuances of the programs and policies that are at play. So, with that said, I'm going to introduce Lenice and hope that her mic works. So, Lenice, I will turn this over to you for the next slide.
Hello. Can you hear me?
Yes.
Okay. So the health strategies for CMS have particular applications for individuals with ADRD that require support and assistance in nursing homes. So CMS has partnered with SAMHSA to maintain a center of excellence for assistance for people with mental health needs and or substance use disorders. The center provides assistance in two forms. So there's training sessions like live conference calls for how to improve care for residents and recorded trainings that can be accessed on demand. And then individual consultation can also be provided to facilities for specific residents based on their conditions. So CMS has also begun auditing residents' medical records in 2023 to ensure that any resident with a diagnosis of schizophrenia, that there's documentation that supports this diagnosis according to the DSM-5 criteria. And in terms of the particular application, obviously for individuals with ADRD, oftentimes these medications are used for behavioral disturbance management and miscoded as a person having schizophrenia. So that would really help with making sure that diagnoses are coinciding with the medical management. We also review the medical record to ensure that facilities attempted non-pharmacological interventions or a gradual dose reduction for residents on antipsychotics because of, unless it's clinically contraindicated. So as we know that these drugs, antipsychotics, pose a serious health risk in long-term care nursing home populations, and they should only be used when other treatments such as redirection have failed and the medication is needed for the resident's safety or in order to provide the best care. And many facilities, not to demonize the facilities, are doing a wonderful job at reducing the use of antipsychotics. There are still some that are having problems and don't know some of the other managements for especially our ADRD patients with behavioral disturbances. Next slide. So I'm going to introduce our next speaker, Pauline. She's going to be talking about the rules.
Thank you, Lenice. Good morning. As Lenice shared, my name is Captain Pauline Carey Martin. I'm with the Clinical Standards Group at CMS, and I'm happy to present this morning a high-level overview of the minimum staffing standards that were finalized last week on April 22nd to ensure safe and quality care in nursing homes. Before diving into the staffing rule, I would like to provide a brief background. In February of 2022, the Biden-Harris administration announced a set of reforms aimed at improving the safety and quality of care in nursing homes, which included CMS proposing minimum standards for long-term care facilities. Next slide, please. The final staffing standards consist of the following three core requirements: a minimum numerical staffing standard, having an RN on site 24 hours a day, 7 days a week, which can include the director of nursing. However, the director of nursing must be available to provide direct care to residents. And also, nursing homes need to conduct an enhanced facility assessment, which includes participation and input from direct care staff. Next slide, please. For the minimum numerical staffing standard, nursing homes are required to have a total nurse staffing of 3.48 hours per resident day to provide direct care, of which must include at least 0.55 hours per resident a day of registered nurse care and 2.45 hours per resident day of nurse aid care, with the remaining 0.48 hours per resident day could be from any combination of a licensed nurse and or a nurse aide care. Next slide, please. While CMS believes that these staffing requirements are balanced and achievable, we acknowledge that some nursing homes may face unique challenges. As such, the final rule includes time-limited hardship exemptions from the numerical staffing standards and the on-site 24/7 RN requirement for qualified nursing homes. So how do nursing homes qualify? Where there are several criteria that the nursing homes must meet, including being located in an area where the supply of nurse staff is not sufficient to meet the area's needs. Again, these exemptions are meant to provide temporary relief, and we expect that nursing homes that receive an exemption will continue to work towards full compliance as quickly as possible. Next slide, please. While CMS believes these final requirements are balanced and achievable, we acknowledge that some nursing homes may face unique challenges, particularly those within the rural communities. As such, the final rule provides a staggered implementation of these requirements over a 5-year period for rural facilities and 3 years for non-rural facilities to allow all facilities the time needed to prepare and comply with the new requirements. Thank you.
Okay, if we could have the next slide, please. Thank you so much, Lenise and Pauline. So this is just to round out the CMS updates and also to balance, the focus. This is to enable robust long-term care and supports, whether it's within a facility, as was just described, as part of the minimum health and safety standards, but also recognizing many individuals live within the community, and currently the authority for CMS to pay for home and community-based services really resides on the Medicaid side. So just to let you know, on April 22nd, CMS released the final Ensuring Access to Medicaid Services rule, and that is the intent is to strengthen home and community-based services that make community living possible for people, including those who are living with dementia. So, in this rule, there's delineation of the expectations, and we'll make the slides available afterwards, so you don't have to. Yeah, you. But the links are relevant here. This includes, the adequacy of provider services, that there is a advisory committee that each state would have, and that the state would have the information that it needs for transparent and strategic decision making. Sorry, I went on to the next slide. Okay. All right. And this is very text heavy, but also including both when things are going well and also planning for when they don't go well. So with that, I will turn this back over to Sarah. Thank you. Over.
All right, thank you very much. So I just wanted to provide a quick update. So this is for the peer-reviewed Alzheimer's research program, which is abbreviated PERT, because I am part of the DoD and we love acronyms so very much. So if you will go to the next slide, just a quick update. So we had our FY24 appropriations come through. Everybody breathed a huge sigh of relief. We have a total of 35 different programs, of which peer-reviewed Alzheimer's is one of them. We were appropriated $15 million for research this year. You can see that we had 2 new programs, glioblastoma and arthritis, but we ended up with about $1.5 billion overall. So next slide, please. The reason that I bring this up is because I know that folks on the line may have relevant research that falls under different programs, such as the ALS program. We fund therapeutic development for ALS spectrum diseases. We have a Parkinson's research program, and we have other opportunities that may be relevant to the audience. So all of our funding opportunities can be found on grants.gov, on the CDMRP website, on ebrap.org, which is where you would actually start your application, and sam.gov for some of our broad agency announcements. But the website is really the best place to start. We have everything up there almost immediately. Next slide, please. So talking a little bit more about the Alzheimer's Research Program. So this program was really created from a congressional direction to investigate the long-term effects of military service, particularly with TBI, on the development of Alzheimer's and related dementias. So you can see that really what we're trying to do is mitigate that impact and fund solutions-oriented research that addresses critical needs to improve the quality of life for pretty much everyone. So we have a mandate for not only benefiting service members, veterans, their families, but also members of the public are included as part of our mission because we recognize how widespread our impact should be. The reason that we really focus too on the military folks is that we have found through many studies, some funded by us, that the veterans who not only have a TBI, but veterans in general have an increased risk of developing dementia after service. And so that risk varies whether based on racial, socioeconomic, and gender demographics, somewhere between 2 and 8 times more than the general population. So we're really looking to do a number of different things. One of them is to reduce health disparities, particularly when we look at the demographics of the military compared to the demographics of the data that's available. We're just not there in terms of solutions that are of benefit to everyone. We're looking to increase knowledge of onset following military service and improve quality of life for people who are living with dementia diagnoses, their families, and caregivers. So caregivers are a crucial part of our research priorities. We're looking to improve diagnosis now. I left that as sort of a priority statement because that can mean a number of different things. And again, we're our fifth aim that we kind of look for is to reduce risk and prevent AD and ADRD in alignment with some brain health efforts that are important both to the DoD and, of course, globally. So next slide, please. So what I wanted to talk about today is that we have released our FY24 funding opportunities. We have 3 funding opportunities. They are the Transforming Care Award, the Transforming Diagnosis Award, and the Transforming Research Award. So for care, this is the mechanism where you could do clinical trials of interventions. They cannot be strictly pharmacological interventions because the dollars just aren't there for that for us. So we would encourage you to find another federal partner for that. But we are looking for person-centered approaches that can really address caregiving, and ideally focus on the dyad of the person living with the diagnosis and their family members or caregivers, because we know that that's a really critical and important approach to any intervention that's going to work. The Transforming Diagnosis Award is to look at reducing barriers to diagnosis. So we're looking for research that will improve technologies or access or other critical burdens that prevent a early, speedy diagnosis. And the Transforming Research Award is looking for risk factor identification, risk reduction strategies, biomarkers, for example, that will aid towards really improving the ability for us to understand and mitigate risk associated with developing dementia. We do a two-prong approach for the mechanism. So you have to submit a letter of intent. I call it a ticket to ride, essentially. That deadline is May 22nd, so you still have time. It is literally an abstract and should not have any more thought than an abstract. I use it purely to recruit peer review expertise. And then our full applications will be due, it says June 12th, but I actually extended the deadline to June 20th, so people have a little bit more time to to work on that. So apologies for that typo. You can see we have some career partnership options, which are meant to encourage capacity in these areas. And I'm happy to answer any questions about those at any time. So you can definitely reach out to Helen and she can direct you to me. But that is what I wanted to kind of give an update on from the peer-reviewed Alzheimer's program. So I hope that everybody can be encouraged to apply, and I will look forward to seeing all the applications come in.
Hello, I'm excited to give you an update from the HHS Alzheimer's Grant Program. On to the next slide. I hope you'll start to see, for those of you who join regularly, some familiarity to the slides. This is intentional. Many of you have been along on the ride with us for a number of years and watched this effort grow over time, a growth that would not have occurred without the NAPA process and without the advisory council's support and help and the members around the table. So this is the intent is to show how is to keep you along the ride with us as this program grows and develops and starts to make a difference. This is again just a reminder of the kind of priorities of the work and the relative size of the investments, with the biggest investment in grants and program awards directly to tribes, tribal programs, urban Indian programs, and HHS direct services. And then the next largest investment in workforce development, education, and training. And that includes caregiver support coaching as a portion of that. We will talk more about outreach efforts, which are really ramping up now. And then the smallest piece is the piece that we need to keep the work going. Next slide. This we're not going to get into detail. This is a slide we hope to sort of continue over time to just begin to give a sense of the trajectory of the program over time, and we'll get into the details as we move forward. Next slide. So the mainstay work is the work in partnership with tribes, tribal programs, urban Indian health organizations. We now have, of course, the first 4 grantees awarded in 2022 and this in their second year, and then the 8 awardees from the third from the 2023 who are in their first year. In this last year, we have the technical assistance team, which involves support, both kind of grant support, but also subject matter expert is visiting each program. And that's been incredibly helpful to get a feel for what it looks like on the ground, the constraints, the resources, the strengths, and to build the relationships. These programs are really built around the notion that the models of care that work in American Indian, Alaska Native tribes and communities will emerge from those communities. And so the more we understand about how they're working and what they're doing, the more we can support that work. We've had a focus this last year on some technical assistance to the clinical services. What we found is that depending on who leads the grant at the tribal level, we are sometimes very much in the community outreach support, and they have very strong outreach and awareness and community engagement. That's incredibly helpful, but they have trouble branching over and merging and sort of integrating with the clinical services. We've also had situations in which we start in the clinical services, and sometimes they have struggled to cross over into the community-based services. So that's been a big focus, so that we get that kind of comprehensive, turfless approach that is necessary for folks. We're bringing the grantees together on a quarterly basis. We just had a call last week. Some really interesting ideas emerged, and I'll tell you just subjectively some of what we hoped would emerge, which is what are the unique characteristics of delivering the care in a tribal setting that make their programs different. We started to hear a little bit of that coming out as they shared with each other. We're bringing a couple of the grantees together in California to present to the California tribes at a best practices conference in May. And we've begun a little more rigorously, sort of a rigorous effort to sort of develop some cross-grantee comparison. So each of them has their own approach, but we're trying to do that within us and trying to do that in a way that translates into a standard framework so that we can see how grantee A and grantee B may solve the same problem the same or differently, and so that they can learn from each other. And I think we've just started with the 3 of the 4 2022 grantees, and I can just tell you it's really interesting, and maybe it might be something to share at one of these sessions over the next year. So the next slide. This is just a slide of where they are. We hope this slide will be populated with other really important efforts like the geriatric nurse scholars and the geriatric the nurse geriatric scholars and the geriatric scholars as well, and we begin to see the spread of the program nationally. Next slide. In this fiscal year, there will be a second NOFO, which is an advanced offering of grant award cooperative agreements. Obviously, we're targeting existing programs that have started to do work in dementia. That will obviously include our current grantees, but also other tribes that may have been further along and didn't apply for the first 2 years. And this will be 3 years, and we hope that the focus on this award will be towards sustainability over that period of time. And we're excited to see who comes. We can move on. Yeah, we're good. Thank you. Other work that you've heard about, and I'll just touch on we have a second round of work with our oral health program as our partner. Integration of the ability to assess for cognitive impairment in oral health. Again, we're not asking them to screen for us. We're offering them tools that they can use when they're working with older patients. And they're trying to understand where there may be barriers to care or where they may need to adjust their care so that they have the ability to do a mini-cog and do a cognitive assessment and understand their patients better. Yes, we want them to send them on to services and make further evaluation, but we also think this will be helpful to them in providing oral health care to their older adults. And they've been terrific partners in that work. We're working with the CHRs in a pilot way to community CHRs of the community health workers embedded in virtually all tribes and HHS services, and they're working to train their CHRs in dementia in cognitive screening, either using the mini-cog or the 88 or similar tools, so they're in the homes all the time. And again, we want them to have this tool. This is part of their toolkit, and to heighten their awareness. And then finally, we're working with the Division of Nursing to continue on in partnership also with ACEP on the geriatric ED accreditation efforts. Next slide. We're completing the second year's work of the geriatric scholars on their programs, and I'll take a minute just to share a little bit about two of the efforts, because I think they really demonstrate the kind of potential impact here. As a reminder, the Geri scholars are physicians, NPs, PAs, and pharmacists. They get supported to do intensive board review level training, and then to take what they learn and develop a project locally that will improve care for older adults. And most of this is an emphasis on dementia and Alzheimer's, not all. They choose the project. They choose the effort based on what their community needs. But there's two I want to just share. One is a small tribal clinic, I think about 500 users, a PA-led clinic. And the Geri scholar there initially wanted to start a screening effort and then decided instead to embed that screening effort in a geriatric assessment effort. So he's looked at his older patients. He's stratified them by age. He's starting with the oldest, and moving downward. He hopes to be able to have every older adult that he cares for over the age 65 have a geriatric assessment and a cognitive assessment as part of that. And he's made significant progress. And of course, this involves not just what he does but his whole team, right? So it's a team effort on this work. And that's, that's the kind of thing that just makes us so excited to see that change. On the other extreme, we have Dr. Maria Bellantoni, who's the very scholar at Phoenix Indian Medical Center, working out of their primary care services. They have about 150,000 patients that they serve in Phoenix in the primary care services. 18% are over the age of 65. And she's begun an effort of increasing recognition and increased recognition diagnosis leading to better management. Started with education, then added in some workflow changes, and she's a geriatrician herself, and so can add into that work geriatric consultation to support the primary care who are doing most of this work. And she's embedded in the primary care services. And they're already beginning to see a trend line of increased recognition, increased diagnosis. And I think she sees this as a long-term. She's developed the support of her primary care services and awareness of this up to the CEO of the hospital. And I think this is an example. Both of these are examples, of the program just puts a little wind at their back. Both of these folks are doing we're doing very little actually for them, except to give them the support, institutional support, to do what they're trying to do, which is improve care for older adults. And it's really inspiring to me. We've also got really exciting work going through the Geriatric Nurse Fellowship. Oh, let me just comment about Indian Health Scholars. We'll recruit the third cohort this year. We'd still love to expand to other disciplines, but we're trying to kind of consolidate and make sure we've got it. We're doing what we're doing well for the folks we've got. The Geriatric Nurse Fellowship is in its first year. APNs, RNs, LPNs, with both some training support and also some backfill support for their institutions. Also all working locally on improvement in their own institutions, and they're really just getting started on that work. And we are hoping to bring a bunch of these folks together in the fall to share with each other and to build that a community, to help continue to build this community and excitement about what they're all doing. The next slide. Our ECHOs are moving into the second year. We're in the process of reevaluating curriculum and building out the curriculum for the next year. We've gotten to, in both the caregiver ECHO and the clinical ECHO, a relatively stable group, which on the one hand is great because these folks come back every time and starting to build community. We also hope to bring more folks in over time. But it's a fairly broad reach. All 12 IHS regions have had folks attend. And it's a great way to get beyond folks who are formally engaged in our programs with us. And also to begin to mentor, to watch folks begin to have these conversations with each other. And we're still working to build capacity. We've got a training and technical assistance contract that it's in process that we hope will help us do more. We've begun some work. There's, a lot of our outreach and awareness has been through these programs, but we're beginning more broader outreach as well. We have some public affairs support and a lot of activities to try to increase just awareness and the conversation about older adults and about living with dementia. One of the things we hear from our grantees, from our Jerry Scholars, is that they're doing the work of increasing awareness in their own tribes and communities. We hope to be able to provide a background to amplify that nationally as well. And certainly our listserv and the community we're working with has continued to grow. One other little, I don't want to lose this. We're working with our Health Promotion Disease Prevention Program, which is a small shop but does tremendous work. And they've got a series of health promotion disease prevention efforts, and they're incorporating now and integrating brain health into those efforts. So this is our way, through partnership of expanding our reach as well. And finally, we continue to sort of try to grow our team and our core processes. We hope that over the next few months, we've got our first first annual report. Now, it's not the first year, obviously. It's 3 to 4 years into the program, but it now gives us a template for annual reports. We hope to have that cleared and released in the next few months, and of course, you all will get that when it's out. There's also ongoing work on development of a data dashboard. And part of our data work is actually I'd say with a team from the CDC we're working together to look at background rates of dementia and cognitive of dementia within the HHS information system. That's been a great partnership with folks at the CDC. I think that's it. Thank you.
Thank you, Bruce. And then last but not least, we're going to start over with Dr. Hodis at NIA and then go to NINDS.
Thank you. Yes, my pleasure to present along with Walter for NINDS of NIH progress, recent events over the past year. Next slide, please. We don't have the very up-to-date numbers for actual expenditures for Alzheimer's since our system lags, but I'll show a couple of slides here to illustrate the way in which this has grown. Here, illustrated for NIA appropriations, and you can see this is illustrated in two colors. It's the top, the blue bar, which represents the appropriation that is congressionally targeted to Alzheimer's disease, and you can see its growth through the current year, FY24. The next slide illustrates this in a different way. This is the year-by-year targeted funding for Alzheimer's disease to NIH. You can see this past year, the current year, 2024, $100 million, $90 million of which went to NIA, $10 million to NINDS, and you can see this is the most recent in a string of years which have progressively increased the funds available for all aspects of important AD-ADRD research. Next slide, please. We've announced the pay line, something that's always very important to the research community. Illustrated here, these are the current allocations. As the fiscal year progresses, they can change, we hope, in the direction of an increase. But if we pay attention to the AD-ADRD pay lines for the most frequent applications, that is under $5 million a year, the threshold is 17th percentile, again, with a premium given to new investigators, that's NI, and early stage investigators, recent in their career post-training, where the pay line is the 22nd percentile. This is for the percentile grants that are reviewed by the Center for Scientific Review at NIH. The next slide shows the same for scores, priority scores given to applications that are reviewed at the institutes, in this case at NIA. And you can see the scores for program projects, for other NIA reviewed. And career development and fellowship remain high priorities as continuing to train and develop early stage and next generation investigators. Next, please. Some updates. Next. So periodically, that is after, in particular, each of our research summits, and you'll remember there are 3 summits that occur in succession. So each year there's a summit. There's the Alzheimer's Research Summit, the Alzheimer's Related Dementia Summit, and the Dementia Care and Caregiving Research Summit. After each of these, which has as their charges to identify progress, opportunities, priorities, we revise milestones that mark our research planning, strategic planning. After our 2023 most recent summit on dementia care and caregiving, new milestones were developed which cover the list you can see here. For example, most importantly, outcomes that matter. A long and important discourse that is ongoing, trying to understand what outcomes in response to prevention or treatment matter most to the individual affected, to families, to caregivers, as well as to care providers. And this has taken flight and strength with a number of focus groups, meetings, and summits that attempt to develop for the use in all of our clinical research benchmarks and progression that really allows us to design the kind of research that matters most in the end to all levels of those affected and their partners. These will soon be added to the research implementation milestones. And I point out here at the bottom of the slide the link that can let you see all of the NIH milestones and all aspects of Alzheimer's research and the progress being made in those. Next, please. Some recently published Funding opportunities. These are the cases where funds are set aside for target areas of research. This follows from the summits and the milestones and the priority setting. And you can see three that are illustrated here. The first is for computational models and at a multi-level identify the dynamic changes that occur in AD-ADRD over time and with age. The second is an open measurement coordinating network for non-pharmacologic AD-ADRD prevention trials. There are a great diversity of trials, and this network, a coordinating center, will work to try to establish common hubs for developing, validating, comparing the outcomes of these preventive measures, and then disseminating measures and measurements as methods for future primary prevention trials. And then an OC that reflects a partnership with the VA in which we are looking through administrative supplements for NIA veterans mentored physician and clinical psychologist scientific awards. This part of an ongoing effort to take advantage of a very healthy and long-term and intense relationship with the VA in which we meet twice a year and compare our priorities and look for these kinds of opportunities to work together. Next, please. This is a list of some of the concepts that were cleared at our National Advisory Council. So to remind you of the process, as a result of summits, all kinds of input, we generate potential concepts for development and clear them as concepts with our Advisory Council. When they are approved, they become candidates for moving forward to funding opportunities. And this is a list of those here that you can see that were cleared at our most recent council. And they span, as you can see, accessing and manipulating brain cell subtypes through drug development programs and on through the courses and other means of promoting research across a broad spectrum. Next, please. Well, back in 2023, congressional language instructed NIA and NINDS to enter an agreement with national academies to identify research priorities for preventing and treating Alzheimer's. And this is just an update of the time frame of that. The task order to the national academies was established a little over a year ago. The committee was established last September. Since then, there have been 3 public meetings, 4 working group sessions, and now the academies will continue through their process. We expect a final report anticipated in January to March of 2025, identifying, again, gaps in some of the most important opportunities for research. And this will be yet another guide to our planning. Next, please. In addition to the more conventional grant mechanisms, we've used a number of occasions now, challenge or prize mechanisms. This is one example, the Eureka Challenge for early prediction of Alzheimer's. And the prize competition is in order to discover the best data for generating early predictors, the methods to do so, and the strategies for early prediction. This was launched in September. And the challenge will offer cash prizes that will total some $650,000 across the 3 phases, those phases being discover the best data, develop methods, and then strategies. NIA has received some 40 submissions, and we expect the prizes to be awarded in the fall of this year. And the next slide shows you the outcome of another prize mechanism, which was highly successful. This is a Healthy Aging Startup Challenge to encourage diversity in aging research and innovation. This challenge had its first iteration in 2022. The second one was held last year with a special interest in identifying solutions that address health disparities in aging population. There were some 20 finalists after receiving entrepreneurial assistance and advice that generated the finalists you see here, which we hope will be the frame for a productive future generations, high success in terms of their establishing companies, commercializing products. And just looking at those challenge winners here, you can see the spectrum of research supported, from mechanically powered assisted walking devices through wearable technologies to identify heart failure, providing patient monitoring to predict surgical complications, and so on. Remarkably successful in bringing people who would not normally be in the NIH research community to bring their talents and vision to bear on highly relevant projects. Next, please. Some announcements. Next. So the next summit coming up is in September this year, September 23rd through 25th. The theme of this is Path to Precision Medicine for Treatment and Prevention. We'll be announcing the agenda as well as registration details, and we'll keep you informed of those. Next, please. And just to note, this is the 50th anniversary of NIA's founding since 1974, led research on a broad spectrum of activities that are relevant to aging, with a very major milestone, as you all know, in Alzheimer's-related dementias. A link where you can learn more about some of the milestones over this history. And then finally, in the next slide, an invitation to join us in celebrating through a series of blogs. Welcome your input. The link's all shown here. And next, happy to turn this over to Walter and INDS for updates. Walter.
Thank you, Richard. I wish I was 50 years old. But I want to talk a little bit about the NINDS research that's going on as part of the NAPA. It's way too much to talk about, so just some brief highlights here. An overview that we focus here at NINDS on the frontal temporal dementia, on Lewy body dementia, on the vascular contribution to dementia, and then on the combination of how these multiple different pathologies cause dementia in the elderly. We have a very robust science going on with over 90 funding opportunities between FY15 and FY24. And at the bottom, there are some major projects, big team science projects that would only be possible under the NAPA appropriations. And we're focusing heavily on trying to understand how we can prevent dementia, particularly by working on the vascular risk factors that lead to dementia, but also looking for ways in which we can diagnose and monitor progression in frontal temporal dementia, Lewy body disease. So next slide. Just a couple of tidbits. This is one recent paper using a technique that came out of the Brain Initiative looking at the microcirculation. So with ultrasound, you can actually look at the very small vessels, the arterioles, capillaries, veins in the brain, entire brain of a mouse. And here in a mouse model of Alzheimer's, what they're showing is that there are changes in the flow that occur as amyloid occurs in the mouse brain before there are any kind of structural changes. So there has always been a lot of work on the connection between blood flow and the need for blood in the brain and how that's altered in Alzheimer's. And this is further evidence at a really microscopic level. Next slide. There are a couple of things that have come out recently that are important to know about, and they are the findings of proteins that are able to diagnose people's risk of developing frontal temporal dementia or Lewy body dementia, as well as Parkinson's. And this one is what's called the synuclein seeding assay. Synuclein aggregates are the signature of Parkinson's disease and Lewy body dementia. And it turns out that looking at spinal fluid, one can find these aggregates in people decades before they develop symptoms of Parkinson's or Lewy body dementia, and is very highly accurate, not perfect, but highly accurate in detecting these aggregates in people with Parkinson's disease and Lewy body dementia. Of note, the most recent data is that there's a significant overlap with about 30% of Alzheimer's cases also being positive for these synuclein aggregates. Further evidence of this intersection between Lewy body dementia and Alzheimer's disease. The importance for patients is that this technique, which is now in spinal fluid, is being moved to skin biopsies, maybe saliva, maybe blood, and it's going to allow people to know if they're going to develop this disease decades in advance, putting a high premium on detection, on treatment. Next slide. The next slide is similar vein. There's a protein called TDP43, which forms aggregates in almost all ALS cases, amyotrophic lateral sclerosis, about 50% of the frontal dementia cases, about 50% of Alzheimer's dementias, and 100% of what's called late. Turns out that this protein, when it aggregates, doesn't function well. Its function is to avoid missplicing. And so when it doesn't function, there are proteins that are made that shouldn't be made. They have a cryptic exon in it, a piece of protein that shouldn't be there. It should have been spliced out. So this may be important in actually the pathogenesis, but I think what people are doing now is trying to find these cryptic exons in assays so you could actually diagnose in blood or spinal fluid whether there is TDP43 aggregates in brain. So both of these latter projects are getting at biological characterization and diagnosis, much following what's happened already in Alzheimer's disease with tau and amyloid. Next slide. And just to sum up, that we have right now 23 open and planned initiatives. We have an RFA that people can apply and pursue their own ideas. We share a common pay line with the Aging Institute, and we're focused heavily on training, research resources, disease mechanisms, translation to develop therapies and clinical trials and clinical research. We're also very interested in promoting diversity in our workforce as we move forward and advancing health equity in this space. Thank you very much.
Thanks, Walter. And then I heard that Eric Weekly has some updates. So Eric, if you have 1 to 2 minutes, we can turn to you before our break.
Thanks. Thanks so much, Helen. I'll be very brief. So I didn't send them beforehand, so thanks for giving us some time. But from SAMHSA, it's a few things. Last week, SAMHSA was part of the release of the National Strategy for Suicide Prevention. So there is a document out that I gave the link for the strategy. There are a number of references to older adults in the strategy, since older adults do have the highest suicide rate, unfortunately. There isn't a particular discussion of Alzheimer's disease and a link to suicide, but there are some studies that do indicate some links that may be there. And we are having an older adult suicide prevention policy academy in the summer. So we're just planning that now. So we don't have the date yet, but we'll get that information out. Unfortunately, it's limited because of just time and space and funding, but we will definitely share the results from that policy academy. We have a brief document for states about mental health and aging and programs that states can implement for services for older adults. And then finally, just as a reminder, if you didn't know, to let you know that Thursday is Older Adult Mental Health Awareness Day, and the symposium, the 7th annual symposium, will be sponsored by ACL, HRSA, and SAMHSA, and with the assistance of the National Council on Aging. And if you would like, I could put the link in the chat if you don't have that information. Thanks.
Great. Thanks, Eric. Over to you, Adrian.
It's been a great morning that we're hearing all the updates that are happening on the federal space. I'd like for you to think about what's happening in primary care. And the doorway to getting access to many of these services is our primary care environment. But there's a challenge. There's actually a crisis in primary care right now. And as a family medicine physician and geriatrician, I think that it's important as we go into our clinical care day that we begin to look at this crisis in primary care. If you don't have adequate primary care, then there's not enough focus or space to be able to do many of the interventions, wonderful interventions that we heard about today. So the National Academy of Sciences, Engineering, and Medicine, NASEM, they looked at this and decided that there is really a challenge. And they developed a report in 2021 looking at what we would need to do to implement quality primary care, because it is a crisis. How can we rebuild the foundations that are needed in healthcare? And the next slide. They came out with 5 objectives because they realized we were approaching this the wrong way. Our payment systems are paying for the doctor seeing the patient rather than paying for a primary care team managing the care. They looked at, we weren't having primary care everywhere. If you're in an urban city, you can get it, but many other places, it's really not available in the communities. Partly because that's not where the training is occurring. People are going to the big cities for the training and their residency, and you kind of stay there because it's comfortable. But we're not training people where other people are living and working. There's been a challenge with the data technology, and Arlene, thank you for developing that new tool that should be very helpful. And I like the fact that your slide said that you're already looking at the integration to Epic and Cerner and all of those, because that would make a difference. But we haven't really designed enough of the information technology for the end user in mind. They're more built around payment and quality reporting, but not so much what that care team needs to document and communicate to the other partners. And so without that, we're not really delivering high quality care. So fast forward to 2024, Millbike created a scorecard looking at the outcomes of those reports. And it's sad. It's 5 reasons why access to primary care is actually just getting worse. It's getting worse. So reason number 1, we're not getting enough people going into primary care. The number of people in primary care is going down continually. Although we have more nurse practitioners and physician's assistants, it is just not enough to meet the demand. We have more larger population, and they're getting older with chronic diseases. And primary care lost a lot of workforce during the pandemic. I think we may all know of people who died because they were frontline. So reason number 2 is kind of like where you train is where you stay, right? And you're also choosing your training based on being able to pay the money back. So 37% of residents were going into a primary care field as of 2021. But 3 to 5 years later, only 15% were practicing in primary care. Because they did their training in hospital settings, so many more of them became hospitalists. No wonder, right? So we're not really training them in the community. If we want people to be working in the community, why do we have most of our residency rotations in the specialties and all these hospitals as opposed to in the community? So there's a disconnect there that needs to be addressed. Next slide is reason number 3. We don't pay enough. I am lucky enough that when I came out of medical school in 1982, my medical debt was $30,000. Unheard of. But I could go through, I had the option of going through HRSA, and for every year that I, would have done payback, I would have gotten $25,000. Well, medical debt now for medical school is astronomical. And some of the repayment has not actually kept pace with it. And so you'd be doing your payback for maybe $25,000, $30,000 a year. But if you owe $400,000, $500,000, it's a life change thing to think about. But the reimbursement across all insurers, commercial, Medicaid, and Medicare, has declined for primary care. Physicians in general, but for primary care, the money is not there. Number 4, It is a technology burden. If I'm having to do an electronic health record, anytime you go to the clinician, what are they doing? Trying to do that documentation because they actually have to do that. And it wasn't designed for us. So AHRQ, thank you. Thank you, Arlene. I mean, when this comes out, hopefully there'll be the resources to get it into all these systems, because when you're trying to do this care for our geriatric patients and persons living with dementia, you really need that care coordination across all specialties and across the community. And the family needs to have it in their hand, the care plan. And that's not what we have now. So, and finally, the research has not really been there to design what is good primary care and pay for it that way. There are some interventions in CMMI, and great, we're very happy about the guide model, which will be in testing for 8 years. But we really need more. I mentioned when they're not going into the field of primary care, they're not being paid adequately, they're not being trained where we need people to live, and the data systems don't fit them. So if we want to make a difference, there's some things that need to be done different to get the door open. So my charge for you today, as we're listening to what the current clinical care system is today, throughout this afternoon, think about what are the recommendations we need to make a difference. So with that, we're going to take a 5-minute break, 5 minute, and we're going to launch into our panels for this afternoon. Each member of the panel is going to speak from the podium here. They just have one introduction slide with their picture on it, and then they'll go into the meat of their presentation. So I encourage everybody to come back in 5 minutes. Thank you.
Produced by the U.S. Department of Health and Human Services.